Okay, hello everyone. Let's get started. Thank you for joining the Genomind Professional PGx Clinician Training webinar. So I'm Dr. Dan Dowd from Genomind. I may have spoken to some of you in the past during one of our personalized clinical consults. Today, I want to introduce you to our brand new flagship product, Genomind Professional PGx. If you have used us before, you're more familiar with the Genotype assay. But since we updated the engine and the body of our new test, we decided to update the name also. So the new name is Genomind Professional PGx, and welcome. One sort of housekeeping thing, I'll ask that everybody hold questions until the end of the webinar. You will notice a chat function within Zoom. Please use that chat function to ask your question. Okay, so as you're probably aware, we like to think of ourselves as more than just a pharmacogenetic test. We think of ourselves as a platform of services to help you with difficult to treat behavioral health patients. In addition to our test, Genomind Professional PGx, all providers get access to GDIG, the Genomind Drug Interaction Guide. GDIG can be found by clicking your patient's name in the Genomind portal. If you're not familiar with GDIG, it's software that incorporates your patient's CYP450 genotypes into any potential drug-drug interactions between medications. So we're hard at work making some updates to GDIG, so stay tuned for that. We'll let you know when that's updated also. Along with GDIG, we built a patient education platform called the Genomind Gateway. And providers often tell us that patients ask time-consuming questions about their genetic results, and we wanted to help with that. So we built a gateway to answer some of these questions using lay language. So Genomind Gateway is designed to remove some of the educational burden away from you and your busy office. Last but not least, we'd like to introduce you to our partnership with NeuroFlow. So NeuroFlow is a collaborative mental health care platform that tracks patient outcomes. And the whole point of NeuroFlow is to improve continuity of care. So our partnership with them is still brand new, but we'll let you know when this functionality is live, and we look forward to our partnership with them. At Genomind, we're really proud of our world-class scientific advisory board. We recently added 3 new members to our board, and I'd like to call them out now. So Drs. Kathleen Brady, Dr. Ruth Benka, and Dr. Naomi Simon. So they bring their expertise in addiction, sleep disorders, and PTSD, respectively. We're happy to have them all on board as part of our SAB. So as we were developing our new Genomind Professional PGx test, we wanted to develop a few golden rules for pharmacogenetic testing. We've condensed these rules down to about 5 that you see here. And many of these rules may seem obvious to our current users, but we feel it's important for new users to understand some of the best practices for pharmacogenetic testing. So going through each one of these, first rule is that PGx, or pharmacogenetics, is probabilistic and not deterministic. It can't identify the perfect drug for a patient. It can't eliminate all risk. Like all other fields of medicine, it provides estimates of risk or estimates of response. PGx is only one part of the clinical puzzle. It is meant to supplement good clinical judgment, a good family history, other lab results, etc. And it should never be the sole source of medication selection or medication dosing. It's just one part of the puzzle. Although we do have genes associated with improved response to some medications, pharmacogenetics still does a better job at assessing safety and tolerability to certain medications. I'll also note that the field is growing very rapidly and new guidelines are routinely being published. And we're going to keep on top of these new guidelines and inform you when these new ones are available. So in addition to our golden rules, we also wanted to address some of the criticisms to pharmacogenetics Some of these criticisms we addressed years ago, but thought we should let you know what we were doing to make PGx an accepted standard of care. So on the left, you'll see some of the criticisms. On the right, you'll see some of our responses to these criticisms. So some critics will say that pharmacogenetic laboratories are poorly regulated. Well, our lab in King of Prussia is state-of-the-art and has every certification necessary, and then some. In addition to CLIA and CAP certification, we obtained our New York State certification, and this is the most difficult one to obtain. In addition, we voluntarily test every single sample in duplicate to ensure the highest level of quality. We're not required to do this, but we want to give you the most accurate results possible. So every sample gets tested twice. Critics will also say there's a lack of data to support pharmacogenetic testing. Later on, I'll show you a slide highlighting the number of drugs that have pharmacogenetic guidance written right into the FDA label, the dozens of pharmacogenetic guidelines that have been published, and multiple meta-analyses, systematic reviews, and genome-wide association studies that support pharmacogenetics. In addition, our own research, when we partnered with Aetna, shows that pharmacogenetic testing can reduce healthcare costs, emergency room visits, and inpatient hospitalizations. Critics will also say that there's not a standardization within the field of PGx. Well, we recently updated the report to align with CPIC standards and guidelines. So if you're not familiar with CPIC is the Clinical Pharmacogenetics Implementation Consortium, and this creates standardization within the PGx industry, and we follow their guidelines. Often critics will also say there's a failure to account for ethnicity within a lot of these gene-drug associations. We recognize that there's clear differences in frequencies of certain genes between ethnicities. And as such, there may be different gene-drug associations between ethnicities or genes that are only present in certain ethnicities. And so we've taken this into account with the new tests and will identify particular ethnic groups for certain drug-gene associations. The concept of phenoconversion is another concept that critics will mention for pharmacogenetics. They will say gene-drug reports don't account for phenoconversion. Now, the term phenoconversion is one that relates to drug-drug interactions in an individual's phenotype. So, for example, you can be born a poor metabolizer, a genetic poor metabolizer, or a drug interaction can convert you into a poor metabolizer. And critics will say, well, you don't account for that phenoconversion with a gene-drug checker. Well, we built GDIG, our gene-drug interaction guide, to account for that criticism. So we built this tool last year, and it accounts for CYP450 related drug-drug and drug-gene interactions. So it addresses this phenoconversion critique. Lastly, critics will say there's a lack of education for providers, for the users of pharmacogenetic testing. So from day one, we've always prided ourselves in our clinical consult program. We think it's an important part of our service. And so we recognize there's a learning curve for pharmacogenetic testing, and we want to be your partner in implementing these programs. So since education is a major focus of ours, we've partnered with Dr. Stahl at NEI, at the Neuroscience Education Institute, to offer a free CME program. So the title of the program is When, Why, and How to Integrate Pharmacogenetic Testing into Clinical Practice. So this continuing education program is worth 1 credit and is available to MDs, to nurse practitioners, and to those with PharmD credentials. So you can see the website here. Visit nei.global/genetics for access to this free CME program. Okay, with all that being said, let's get started with a view of our new product. Once again, its new name is Genomind Professional PGx. Internally, we call it GenPro. So this is a 100-yard view of the new report. It now contains 15 total pharmacodynamic genes and 9 pharmacokinetic genes. Within these pharmacokinetic genes, we have a new gene related to drug absorption or brain permeability. Our gene-drug interaction summary organizes drugs by class and organizes gene-drug interactions. Former Genotype users will remember this as our checkmark system, our series of orange, green, and blue checkmarks. Well, that's been updated. We also created brand new summary pages, and these pages were created by popular demand. Many of our providers requested a more visual organization of this information. And so our summary pages are meant to be your at-a-glance view of drug-gene interactions. Lastly, we created a patient wallet card that includes their CYP450 genotypes, and this is meant to be shared with their next provider. So here's a summary of our pharmacodynamic genes and how they relate to particular drugs. As always, our genes help inform about treatments related to depression, anxiety, antipsychotics, drug-induced weight gain, ADHD treatments, opioid sensitivity, alcohol abuse treatments, and the use of mood stabilizers. If you're a former Genotype user, then you recognize most of the genes here. You may be unfamiliar with HLA-A or HLA-B or HTR2A, also known as serotonin 2A. These are the 3 new pharmacodynamic genes on our report. They're related to risk of drug-induced skin reactions and antidepressant response, respectively. So let's talk about each one in more detail. HLA-A and HLA-B are genes related to important immune system proteins. Clinically, they identify people who are at a higher risk of severe skin reactions to carbamazepine, to oxcarbazepine, to phenytoin, and possibly lamotrigine. So these genes are even identified in the FDA labels of some of these drugs, and CPIC has published guidelines related to both of them. Again, CPIC is the Clinical Pharmacogenetics Implementation Consortium, CPIC, and is widely considered the authority on standardizing pharmacogenetic practice. Notice the link to the CPIC guideline at the bottom of the page. Okay, more about CPIC in a minute, but this link is actually embedded in your new report. So you can click on that and it'll bring you right to the CPIC guidelines for some of these medications. So the frequency of HLA-B 1502 is concentrated in Asian ethnicities. So this gene is associated with increased risk of severe skin reactions to carbamazepine, oxcarbazepine, phenytoin, and phosphenitoin. To a lesser degree, it's also associated with lamotrigine skin reactions. And if you look at the red portion of the chart here, you can see that it's rarely found in the Americas, in Africans, or Middle Easterners, but is found anywhere from 4 to 7% of the time in individuals of Asian ancestry. HLA-A 3101 is associated with risk of severe skin reactions, but only with carbamazepine. Okay. HLA-A, carbamazepine only. HLA-B, carb, oxcarb, phenytoin, phosphenitoin, and possibly lamotrigine. HLA-A is found in all ethnicities with a concentration in Asian and Central and South American populations. I'm going to add some more context to the increased risk of skin reactions with certain genes. This chart identifies the background rates of severe cutaneous adverse reactions, such as Stevens-Johnson syndrome or TEN, toxic epidermal necrolysis. So the data that you see here is from the FDA labels of carbamazepine and lamotrigine. Although background rates for severe carbamazepine sensitivity are rare, on the order of 0.06%, having a positive HLA genotype can increase your risk almost tenfold, while a positive HLA-B genotype can increase your risk over 100-fold. When it comes to lamotrigine, it's a little different. Background rates are more common, about 0.8% for kids, about 0.3% for adults, but the odds ratio for genetic risk is much lower. It's about a 2-fold increase in the risk of these skin reactions when HLA-B is positive. In the last column there, you have some PubMed IDs and also the link to the CPIC guidelines for HLA-A and HLA-B. So coming back to CPIC, we mentioned earlier that CPIC has a role in standardizing pharmacogenetics. CPIC consists of a group of researchers that specialize in pharmacogenetic research from major institutions across the country. They've produced peer-reviewed pharmacogenetic guidelines related to many mental health treatments, SSRIs, for example, tricyclic antidepressants, some opioids, atomoxetine, all have CPIC guidelines. And all of these guidelines you can see for yourself if you go to cpicpgx.org. CPIC also works closely with PharmGKB, which is a fantastic database of pharmacogenetic research. You can see the links to the two of these at the bottom of the slide. Since we mentioned CPIC, this might be a good spot to summarize the evidence and guidelines surrounding PGx testing. So the FDA has many drugs with pharmacogenetic dosing instructions or warnings in the label. Aripiprazole, citalopram, codeine, tricyclic antidepressants, atomoxetine, to name a few. 36 drugs on our new report are associated with FDA pharmacogenetic precautions, warnings, or dosing guidance. Many of the drugs on the new report have CPIC guidelines associated with them, and others are supported by meta-analyses, systematic reviews, or genome-wide association studies. So this literature can be found in our 2019 white paper literature summary, which is on the clinician portal. Click in the clinician portal, go to the resources page, and you can find our white paper literature summary. So back to some of the new genes on our report. Serotonin 2A is our final pharmacodynamic gene addition, and it provides information on the odds of response to certain antidepressants. Serotonin 2A is the gene that codes for the serotonin 2A receptor, a common site for antidepressant and antipsychotic binding. In the new report, it would identify individuals who are less likely to respond to non-SSRI antidepressants, but also more likely to respond to citalopram. Though the mechanism isn't entirely clear, a meta-analysis found a 3-fold difference in remission rates between drug groups based on this genotype. Here's the forest plot of the meta-analysis that I mentioned. It's meta-analysis by Niitsu. As you can see, the odds ratio of remission to SSRIs versus non-SSRIs is 3.19, so about a 3-fold difference between groups. AA homozygotes are less likely to respond to SNRIs, tricyclics, bupropion, or mirtazapine. So in addition to our new pharmacodynamic genes, we've added several new pharmacokinetic genes to Genomind Professional PGx. All of your favorite CYP450 enzymes are still accounted for, but now they have some company with UGT1A4, UGT2B15, and ABCB1. The UGT genes are similar to the CYP450s in that they are responsible for metabolism of certain drugs. ABCB1, however, is unique in that it affects drug absorption and blood-brain barrier penetration of select antidepressants, antipsychotics, and some opioids. So drug metabolism can be broken down into 2 different phases, phase 1 and phase 2. CYP450 enzymes are responsible for phase 1, and their purpose is to make drugs more water-soluble. A more water-soluble drug is excreted better. Phase 2 metabolism is often called conjugation and usually entails placing a big bulky chemical entity onto the phase 1 product. Conjugation usually deactivates or suppresses drug activity. UGT enzymes are phase 2 enzymes. They are conjugation enzymes. UGT are enzymes that metabolize some common medication. UGT1A4 is the primary enzyme that breaks down lamotrigine. And so some of us are genetically fast metabolizers of lamotrigine. Some of us with this genetic variant have serum levels that are 50% lower of lamotrigine. UGT2B15 metabolizes many benzos. It's fairly common for some of us to be intermediate metabolizers of benzodiazepines, for example, lorazepam and oxazepam specifically. Genomind Professional PGx clearly identifies the benzos that are substrates of UGT2B15. So this graph is taken from a systematic review by Stingel et al. In 2014. It relates different UGT genes to changes in serum levels of certain drugs. I've highlighted a few of the relevant drugs with arrows here. You can see lorazepam, lamotrigine, oxazepam, and olanzapine. And serum levels are affected by 50% or more for lorazepam, lamotrigine, or oxazepam, whereas for olanzapine, it doesn't have a major impact. And so UGT1A4, even though olanzapine is a substrate of it, doesn't appear to have a major impact on serum levels. So ABCB1 is our first gene related to drug absorption and blood-brain barrier penetration. This gene encodes P-glycoprotein, also known as PGP. This protein impacts the intestinal absorption or blood-brain barrier penetration of several drugs, including antidepressants, antipsychotics, and opioids. Genetic variability allows some of these drugs to penetrate the brain to a greater degree. This can lead to side effects and, in some cases, a more pronounced effect of the drug. So we test for two different variations of this gene. One variant is associated with antidepressant sensitivity, specifically the following antidepressants: citalopram, escitalopram, fluvoxamine, paroxetine, venlafaxine, amitriptyline, nortriptyline, and trimipramine. And if you forget all that, don't worry about it because it's clearly labeled on the report. The other ABCB1 variant we test for is associated with side effects for the following antipsychotics: aripiprazole, clozapine, olanzapine, and risperidone. Okay. Lastly, that very same variant impacts the brain penetration of codeine, fentanyl, morphine, oxycodone, and tramadol. So I know I rattled off quite a few medications there, but each medication is clearly listed as a PGP substrate on the new report. So to drive this point home with a ridiculous analogy, we could think of P-glycoprotein as a bouncer whose one job is to prevent toxins from entering your sensitive organs. In fact, all of your most sensitive organs are surrounded by PGP: the brain, the intestines, the placenta in a pregnant female, and most of us have plenty of this strong bouncer to prevent toxins from entering these organs. But due to genetic variation, some of us make a wimpy version of P-glycoprotein. And so those of us with the wimpy gene allow more medications to be absorbed in the intestines and absorbed into the brain. So these individuals can have greater exposure to some medications and thus greater sensitivity to these medications. Greater sensitivity, however, is a double-edged sword. It can lead to more side effects, but also to a more pronounced response to a drug. The studies shown on this slide support this concept. We'll start with the study by de Klerk, which found that patients with an ABCB1 variant we're about 2.5 times more likely to suffer side effects from select antidepressants. This makes sense. Greater exposure can lead to greater side effects. A separate study by Breitenstein, however, found that ABCB1 variant was associated with higher odds of remission. So drug sensitivity cuts both ways. You're more likely to remit on certain antidepressants, but also more likely to have side effects. So the take-home message here is that if you dose adjust accordingly, you may be able to achieve those higher remission rates while minimizing side effects. So those are our 3 new pharmacokinetic genes. As always, your 6 CYP450 genes are still part of Genomind Professional PGx. CYP1A2, CYP2B6, CYP2C9, CYP2C19, CYP2D6, and CYP3A4 and 5 are all still there. In order to be consistent with CPIC guidelines, we have updated our CYP2B6, CYP2C9, CYP2C19, and CYP2D6 algorithms to reflect the CPIC algorithms. We'll continue to monitor CPIC updates quarterly to be consistent with standardization in the field. I briefly want to remind you that you all still have access to GDIG, the Genomind Drug Interaction Guide. You can find GDIG by clicking on your patient's name in the Genomind Clinician portal. From here, you can enter a medication regimen, or you can just test drive different options to see if there are any major CYP450 drug-drug or drug-gene interactions. Think of GDIG as an interactive version of the report. And we're hard at work adding the UGT genes and the ABCB1 genes to GDIG, so stay tuned for that also. The last thing I'll say about CYP450 is that our lab has started to screen for a few additional variants. Some of these variants are really rare, but they can have an impact on drug exposure. So first off, we added CYP1A2 star 1K. This is a rare allele, but it's one of the only reduced function variants of CYP1A2. So now, in some cases, you can have patients who are intermediate metabolizers at CYP1A2. We also added the star 4 allele for CYP2B6. This is a gain of function or increased function allele. Patients that carry this SNP may hypermetabolize some drugs. Bupropion would be a good example. And our last new CYP450 SNP is 2C19 star 35. So we added this SNP due to a recommendation by the Association for Molecular Pathology. So it's a 2C19 variant that exists independently, almost exclusively in those of African ancestry. So it is a loss of function allele, and now we can better identify our African ancestry patients who are intermediate or poor metabolizers of certain drugs, escitalopram or sertraline, for example. To wrap up our new gene summary, I thought I would just present this visual of all of our current genes. So as a reminder, there's 24 total genes on the new report. 15 of those are pharmacodynamic, which you see on the right, and 9 of those are pharmacokinetic, which you see on the left. All right, let's talk now about some of the new drugs on the report. There have been quite a few groundbreaking drugs to hit the market recently. We want to make sure that they were on our new report. So, for example, FDA recently approved esketamine. There's also an FDA cannabidiol product that recently hit the market. And these are 2 examples of medications we added to the report. So taking cannabidiol as an example, it's metabolized by CYP2C19 and 3A4. So this information could be useful in managing patients taking this medication. We added phenytoin to the report largely because it's impacted by the HLA-B variants. New Dexta, which is dextromethorphan quinidine, a couple of drugs related to tardive dyskinesia, and pimavanserin. There's also a new drug called exercise, which we've added to the report. And the BDNF gene is related to a more beneficial, a more pronounced response to exercise. So exercise is a medication for some people. So in order to make room for some of these new drugs, unfortunately, we had to remove some other medications. So the criteria we used was that any drug that did not have a current FDA-approved indication for brain health was removed. You can see the list of drugs here that were retired from the report. Of course, feel free to ask about these medications during consults, and they're still available in GDIG, so you can enter these medications to get a gene-drug interaction assessment. As the field of pharmacogenetics grows rapidly, we want to be consistent with new information regarding our genes. For that reason, we made some updates to the interpretation of a few of our old genes. So we'll start with BDNF. So the interesting thing about BDNF is that it provides information about antidepressant response that differs between Caucasian and Asian ethnicities. We highlight that as part of the new report. For example, in Caucasians, BDNF MET carriers may respond better to SNRIs or tricyclics. This comes from a large trial in over 350 Caucasians. In Asians, however, 2 meta-analyses support higher response rates with SSRIs in BDNF MET carriers. So we've added this information to the gene results page, and we've also called it out with a new ethnicity-dependent response icon that you can see right here. A couple of updates for COMT or COMT as well. COMT seems to impact the sensitivity to opioids. COMT-Val-Val can be less sensitive and thus may require higher doses for analgesia. The opposite association exists for COMT-Met-Met. COMT-Met-Met patients seem to be more sensitive to opioids and may achieve pain relief with lower doses of opioids. The last gene I'd like to mention is SLC6A4 and the subtle differences between the 3 genotypes. So as you know, you can be long homozygote, short homozygote, or long-short heterozygote. And we want to be a little more specific in describing the genotype associations for each. So long tend to be better remitters, responders to SSRIs. Statistically, they're more likely to tolerate SSRIs as well. Shorts tend to be poorer remitters, poorer responders to SSRIs. They're associated with a greater likelihood of side effects. So one meta-analysis comparing long patients to short patients found that there was about a 70% greater likelihood of remission in long patients to an SSRI. LS, long-short, is actually the most common genotype. It has not been strongly associated with remission to SSRIs, but has been associated with side effect burden. Most consistently, GI side effects, diarrhea, for example. So when you evaluate this gene and SSRI tolerability, think of it along a spectrum. Longs tend to tolerate SSRIs the best, long-short moderately, and short the worst. So the new report reflects these differences. This is how the drug interaction summary would present a short versus a long short. On top, you can see a short, and we make a reference to odds of remission or response. And on the bottom, you can see the more common long-short variants, where the only reference is in regards to gastrointestinal side effects. So we have some new genes, we have some new drugs on Genomind Professional PGx, but we also have a new design. So as you view the new report, you'll see that the gene results pages look very similar to what you saw on Genocept. We present the gene, a short description of its impact, and then a clinical summary. And as before, genes are color-coded. Red and blue genes are considered actionable, whereas green are considered normal or standard or wild type. One major change to the new report is with the gene-drug interaction summary. This is the part of the old Genotype report that contained a series of check marks. Quite often we heard that the check marks were confusing and not intuitive, so we replaced them with a short body of text that describes the gene-drug interaction. While this may make our report a little longer, it is far more descriptive. So an orange check or caution check mark has now been replaced with an orange caution alert icon. As you scroll through the interaction summary pages, your eye can focus on this orange icon to identify any drugs that have some type of genetic caution associated with it. So in this example, a lower odds of remission for SSRIs. Note that the genes responsible for this interaction are listed in the pharmacodynamic gene column. A blue light bulb signifies some type of positive gene-drug interaction. So in this example, higher odds of remission to SSRIs in Asians. Notice again the emphasis on different ethnic groups. You may notice two small icons next to some of these drugs, a RX icon and a notepad icon. The RX icon signifies that this drug has a pharmacogenetic dosing guideline or warning written into the FDA label. The notepad icon designates a similar guideline from CPIC. So the last thing I'll draw your attention to is the drug exposure column. This column will contain an up arrow or a down arrow and is meant to estimate your patient's expected blood levels or brain levels for that drug. In this example, all arrows point up. So this tells us that we expect blood levels or brain levels to be elevated for this drug in this patient. The intervention here could be to decrease the dose or select a drug that goes through a different pathway. As always, the substrates for each drug are listed in the pharmacokinetic gene column. So one of our favorite updates to Genomind Professional PGx is the new diagnosis summary pages. Think of this as your at-a-glance page. It allows you to compare multiple drugs based on pharmacogenetic parameters in a concise visual plot. Drugs will be shifted left when they have a risk gene associated with them. The more significant the risk, the greater the shift. For example, a poor metabolizer at 2D6 would move paroxetine further left than an intermediate metabolizer would. Conversely, a drug would be shifted to the right if it was associated with a greater likelihood of tolerance or response. The great news is that we also tell you why a drug was shifted with intuitive icons. You can see the icons listed towards the bottom there. Was this due to an expected change in serum levels via arrows? Was this due to a lower likelihood of response? You can see a decreased efficacy icon. Or maybe this was due to a higher risk of weight gain. You can see a scale which represents a weight gain risk. So we've created these summary pages for the following 6 conditions: depression, treatment-resistant depression, anxiety, ADHD, bipolar, and pain management. There's a lot of information packed into each page, and there are more to come. OCD, for example. So I just want to emphasize the interpretation of the summary page. Focus on the bolded center line here. Drugs that straddle this line are considered standard options. In other words, we have detected no genes that impact this particular drug. So desvenlafaxine would be an example of a standard option. Some drugs are shifted to the left by varying degrees. This signifies some type of genetic caution or alert for that particular drug. Bupropion, for example, is shifted to the left with a down arrow represent lower blood or brain levels of bupropion. Fluoxetine and paroxetine up here are shifted to the right. This tells us there is a gene associated with a positive response for these drugs, and no other caution genes have been detected. So we'll only shift a drug to the right in the absence of genetic risk. Okay, so this is just a quick view of our depression, our bipolar, and our ADHD summary pages. Some drugs sit along a center line, some drugs are shifted to the left if there's a caution, some drugs are shifted to the right if there's a positive association. You can see in this instance, carbamazepine is shifted all the way to the left with a do not initiate icon. This person happens to be HLA-B positive, and so we want to make sure they understand that carbamazepine is a high-risk drug in this scenario. Okay, this is just a closer look at some of the icons on our summary page. Again, we have a weight gain icon associated with weight gain with some of the second-generation antipsychotics. We have a do not initiate icon. We just saw this with carbamazepine. You can also see it with oxcarbazepine. We have a decreased or increased efficacy icon related to some of our antidepressants, ADHD meds, antipsychotics. A side effects risk icon, again related to some antidepressants and antipsychotics. Decreased or increased sensitivity to opioids. Could provide information about higher or lower doses. And we talked about our ethnic dependent response icon, which differentiates response between ethnicities. Okay, the final new addition to Genomind Professional PGx is the RX MetaType Card. This is part of the report that includes patient-specific CYP450 status. It's meant as a wallet card that a patient can bring to their next provider. So think of it as the equivalent of a medical alert bracelet. We know that CYP450 gene variants can impact drugs outside of psychiatry, so this information can be useful for the next provider. In addition to the patient-specific information, we include links to the FDA table of biomarkers, to the CPIC guidelines, and also to the Flockhart table. The Flockhart table is maintained by the University of Indiana and lists drugs that are substrates of specific CYP450 enzymes. So with this information, a cardiologist, for example, can determine if a blood thinner is affected by CYP2C19, or if a blood pressure medication is impacted by CYP2D6. So patients should be empowered to use their own genetic information, and we created this card so they have access, easy access to this information. So that's everything. That's our new report, Genomind Professional PGx. It contains some new genes, contains some new drugs, and some new visuals to aid interpretation. As always, you have access to our medical affairs team to discuss any of your reports. We want to be your partner in personalized medicine and appreciate your support. So please let your sales manager or local medical science liaison know if you have any questions. And once again, welcome to Genomind Professional PGx.